certified manual therapist. He has presented and worked both locally and nationally. In fact, you were born in this area, or at least grew up
just a mile from here. I was born from a mile from here.
So he's truly a local of the area, and I guess he's more of the host for this conference than I am because he's right here. As I just mentioned in the other room, it's very exciting for me to have Dr. Schweitzer up here as a presenter. He has been to this conference multiple times as an attendee, given us great feedback over the years on things we can do, and I was excited to actually add him to the faculty this year. He brings a wealth of knowledge and enthusiasm and experience to the faculty of this conference, so I'm looking forward to having him as part of it for years to come. Outside of that, he's one of the more interesting people to follow because he was in Nepal recently and next week is going to Patagonia. So I'm going to have to start living vicariously through Dr. Schweitzer's exploits because I'm sort of stuck here. But anyway, I'm excited to see the presentation. This is one I've been looking forward to since we put the thing together. So without further ado, Dr. Schweitzer.
Thank you. Okay. Everyone can hear me okay, right? Good morning, and welcome to day 2. Did everyone get their pre-dawn 6-miler in? No? Me either. I'm an evening runner. Who is a morning runner? I don't know how y'all do it. I love you. I don't know how you do it. All right, let's talk about screening to prevent running injuries. First, if you've traveled from afar, can you believe that this is my hometown? Thank you, Mom and Dad, for picking such an awesome place. Welcome to town. So one of our heroes, Benjamin Franklin, once famously said, "An ounce of prevention is worth a pound of cure." So I went to the trusty internet to find the meme of all memes, honoring this wonderful quote, and I found this odd and confusing cigarette ad bastardizing good old Benny's quote, and I had to share. But the take-home message is still clear. A little bit of effort up front can make an enormous difference in the back end. And we're all healers in this room, so I ask, why not make the most impact through prevention? We all know that it's a bigger impact than post-injury treatment. So here are our lecture goals. And in order to prevent running injuries, we have to screen to discover risk factors. The screen has to be easy and quick and require very little equipment for any of us to do it routinely. And now I want you to remember that this is an overall screen, and much more can be looked at in the runner, as Scott demonstrated yesterday. But I want to get a quick glance at some injury prognosticators if we have a few minutes with someone, okay? That's the goal. So based on current running injury prevention evidence, I compiled this screen using 3 questions and 5 movement tests. That's it, 3 questions and 5 movement tests. So why screen runners? Especially, why screen an uninjured runner? The answer is because they're likely to get injured. The overall incidence rate, according to 24 studies, is 19 to 92%. And that is profound compared to other sports. And 97% of those injuries are microtraumatic and therefore likely preventable. And where is the injury location, generally? Well, 42% of the time it's at the knee. And 3 of the top 5 running injuries are in the knee. So let's think about this. The knee is in between 2 joints, the hip and ankle, both of which must carry mobility and stability very well. And if they don't, we find the knee takes the brunt of the force. So in a recent review of the literature, there were 51 articles found that provide some degree of evidence, either neuromuscular or biomechanical evidence, that proximal tissues can affect distal loading. So the hip and pelvis and the trunk affect how the knee takes stress. And we can find the reverse to be true about the ankle effects on the foot. So if we want to make the biggest impact on an injury risk profile of a runner, then we start with the established risk factors, which are in the left column. Based on these known risk factors, there are 3 questions that must be part of any pre-injury running screen. And in fact, I would say these questions must be posed to every runner. Now, for your future reference, and for the sake of time, I listed the potential and non-factor risk factors in running-related injuries that you can review later. They're in your handout. So here are the 3 must-ask questions of every runner. How long have you been running, and how competitive are you? Do you have any previous injuries, and what's your training regimen like? Note that the new runner and the highly competitive runner are the most at risk and therefore need the most education. When you're discussing running, listen for fishy answers that tell you that people fit into one of these categories, that might make you ask further questions. And we've all heard, running-related statements that just make you shake your head. But here are just a couple examples. And these are what patients have said to me. My sister said I have to run it with her even though it's only in 2 weeks. Right? They're just basically telling you they're going to get injured. That's what they're doing there. I have Chicago and then New York back-to-back. Now, we all know a runner who can do that. But I'm going to propose, based on the evidence, that might be the minority. And those people at least need to be educated about the risk. I've had Achilles tendonitis 3 times this year, but I feel good now. You'll be fine. No one will come back, right? So but let's talk a minute about previous injuries. Previous injuries is a big deal. Any runner with a previous injury requires extra education. They've got to pay extra attention to the signs of injuries. They have to modify other determinants of injuries. It might be the number one injury, but it's not the only, the number one predictor of injury, but it's not the only one. And most importantly, they have to take the time and get the guidance to recover the tissue fully to get back to running at their desired distance and speed. Avoid the wait and see method. Because runners want to do that because they don't want to face the truth. They don't want to, they're busy, whatever, all the excuses. But if you're a referring physician, send them to a good PT with education about how important it is to see it through until they're running at the desired distance and speed. If we stop short of that, we leave them vulnerable. Now, and then a quick note about how that would be treated in PT, real quick. The goal is to stop the cycle of mechanical abuse that's being put on weakened tissue. That's what's happening. And that can come in 2 forms. We can strengthen the tissue, or we can lower the force that's being put on the tissue, right? So sometimes that lowered force might be a temporary change, like a walk, run, or modification of shoes or whatever. Or it might be a long-term change, like some of the knowledge that Scott was sharing yesterday about gait modification. But it isn't just strengthening tissue, it's also modulating, if necessary, the stresses that are being placed on the tissue if they're not performing efficiently. All right, when it comes to training regimen, I'm going to guess that few, if any, clinicians have the time and possibly the knowledge to really educate someone thoroughly on a proper training regimen for their skill set, for their desired goals. That's a whole body of knowledge. And therefore, I strongly encourage that you recommend coaching. Let's recognize that coaching is a part of sports. Most sports have coaches. Kind of surprising that a sport with a relatively high injury rate has a relatively low coaching ratio to public who runs. Referring a patient to a coach just adds a set of early ears, right? For early symptoms. And they get the patient to you quicker, and you can think of that as prevention. That's really what that is. Catching something early is a form of prevention. And bonus points if you can get a coach for elite runners versus a coach for the everyday runner, because those 2 groups do have different needs. All right, we're going to take another minute on previous injury, right? This lecture is about preventing injury, so we've got to talk about the number 1 risk factor, and that's previous injury. Why is previous injury so definitive? One is that the new injury is an exacerbation of a previous injury. And it might take a slightly different shape, or there might be some time in between where they think they got away from the injury and it comes back. We do find persistent post-injury neural inhibition in previously injured tissue, and it's theorized that we would find scar tissue at least decreased tissue mobility in previously injured tissue. And both of these factors can lead to eccentric weakness and possibly atrophy. And both of those things lead to another injury in the future, right? Or at least leave them vulnerable. What do we do about it? We educate people with a previous injury. I'm going to emphasize that again. We tell them that close counts and horseshoes and hand grenades, not getting yourself better for running. So see it through until desired distance and speed is achieved. Second way the previous injury manifests in future injury is the injured runner adopts a different biomechanical pattern in order to protect the injured area and therefore passes compensation on to other areas. So either way, there's a potential change in biomechanics due to a previous injury. So remember, the gait cycle is an orchestrated symphony of timely events, and when one of those events is omitted or impaired, compensation is passed to other areas for compensation and to perform the task. So this leads us to look at the biomechanics of someone's movement as it relates to running. Now, why not look at the entire movement? I'm just presenting a screen. So what about looking at 3D analysis, high-speed video on the treadmill? You should do that. But I'm presenting a screen for those in the room who either don't have the time or the equipment to do that. And we're looking at getting a glimpse of whether someone has the ingredients to run. That's what we're looking at here. So, are biomechanical factors associated with running-related injuries? And the answer is yes. This is the evidence-based list of factors that have been found connected to running-related injuries. And if we can boil this list down to a few things that we can screen, then we can prevent future injury or reoccurrence. Now there's 4 variables just related to eversion. I put them all on the second line. But I don't have a measure of eversion in my screen, and there's 2 reasons. One is you need high-speed video to assess dynamic eversion. It happens faster than your eye takes pictures. And number 2, eversion can be controlled from above. Remember I said 51 articles support the concept that proximal structures affect distal loading. And a good example of that that's running related is excessive hip adduction and internal rotation will cause the knee joint center to move medial, right? And the foot is still stable on the ground, so that'll cause the tibia to rotate and cause pronation eversion. So if we have good eccentric control of that femur, we're going to decrease any number of those eversion variables. Now, the common theme here, we need all these motions to run, but the common theme is don't be in any of them too long, too often, or too much. Too long, too often, or too much. So stability plays a huge role in preventing injury, and we're going to get to that. What inspired me to start thinking about this, creating kind of a screen, was the clinical prediction rules, which have been around for at least as long as I've been practicing and helped guide my treatment. A clinical prediction rule is when you try to identify a combination of signs and symptoms and other findings to predict an outcome, dysfunction or disease. And functional movement screen is really directly influential in me creating a screen that is better for runners. So the FMS, for short, uses 7 athletic movements to detect deficits in movement patterns, strength, flexibility, motor control. It's fairly simple and has strong interrelated reliability, and it does have some predictive value in injuries in military, public service, and in athletes, but it is not run specific. It's designed for all athletes. So the major complaint is that it would be too broad. But there are 2 movements in the FMS that I think are fantastic for assessing the overall ingredients of a runner. Okay, so we're going to borrow 2 of their movements. So if we're going to do a quick biomechanical screen of a runner, then we have to know what's needed to run, right? And the answer is a lot. But remember, I said running is an orchestrated symphony of timely events. And to summarize, it's a blend of mobility and stability. So we can ask, what are we commonly lacking? What are humans commonly lacking? Especially in a sport that people go from the couch to 5K, right? Where would we commonly not have the ingredients that's needed to run? And then what's easy to measure? So humans are often commonly lacking in hip extension and ankle dorsiflexion, both of which are critical for running. Humans are also commonly lacking in stability, in trunk core stability, hip and pelvis stability, and in foot core and posture. So of these measures, which are quick and easy to measure, actually all of them are. All of them are. So from this data, I've created a movement screen based on where humans are commonly lacking the necessary ingredients for running. Okay? All right. So what happens if someone does not have the required range of motion to run in the ankle or hip? We could spend a day on the possible troubles that occur from limited range of motion of the ankle and hip in human locomotion, much less running. And I have listed some of the possible unfortunate outcomes from these limitations. But to summarize, both of these limits in range of motion cause a change in the way you store and release elastic energy, and therefore affect your propulsive power and your push-off. Okay, that's what it boils down to. Now you're still needing to get to the finish line, and you still need to get the PR. So you have to find that propulsive power somewhere, so you're going to compensate. You're going to compensate, and that leads to a mess of problems. So the same concept with stability. A lot can go wrong when we have poor stability where it's needed the most, the trunk, the hip, and the foot. But again, overall, just to simplify it, we really need forces to dissipate through mostly muscle tissue. Scott stole my fire. I was going to do this, like, what happens if I jump off the stage and I don't bend my knees? But he said that yesterday. But I'm going to say it anyway. What happens if I jump off the stage and I don't bend my knees? The skeletal system takes the shock, and one of y'all drives me to the hospital down the street. So, for muscle tissue to absorb force, we have to control the motion and we have to align the tissue. We have to line it up and control the motion, because that affects muscle length tension relationships. And that ultimately affects muscle performance. Trunk control has a strong effect on pelvic positioning. And if you have a poor trunk, you have poor motor control in the trunk in the sagittal plane, your pelvis will dip forward, which will cause your femur to internally rotate and adduct, which causes your knee joint center to move medially. It causes that cascade of problems that you've heard repeatedly, because it's very common in poorly conditioned runners. But ultimately, when it comes to stability, we want to optimize the transfer of energy through preventing being in any position too long, too often, or too much. Okay, that's what it boils down to. So these are 5 tests to assess injury risk based on the evidence. These tests are quick, they're easy, they require hardly any equipment, and most importantly, they hit important areas of mobility and stability. Now I'm going to show a quick video for each of them, and then we can assess each other on all of them with a Thomas test, because you need a table for it. The handouts in your packet have the steps. So the video will help you see what we're doing, and then if you need to remember a step, you can have that handout when we break out and test each other. I've offered one key exercise for each test. There's 1,000 exercises for each test.